Thank you, and thank you for having me here in Boston. Actually, I haven't been very often in Boston, so it's been a pleasure. And I'm going to try to entertain you for 45 minutes or so. I know that you must be a little bit exhausted now. There's so much information here, and it's sitting down all the time. So take 10 seconds, stand up, and just do this a little bit. I want you to wake up a little bit. Just do that, please. That's good. That's enough. Fine. Thank you. Thank you. So, these are my disclosures. And my background is a little bit varied, actually. I'm coming from an orthopedic surgeon perspective. So, I am actually a chair in Oslo at the orthopedic department, doing for the most part sports medicine. And then I've been working with Olympic athletes for a long time, for Norway. But I also lived, I lived 1 year in South Dakota in 1966-67. I lived in Minnesota for almost 10 years, from 87 to 96. So I know what's going on in the US for the most part. Now, when I came back to Norway, and during my time in Minnesota, actually, I was interested in knee ligaments, and I still am, and in cartilage. And then I will tell you how I changed my life a little bit when I came back. And then I became head of science in the IOC 2007. And then I've worked with the ESCA in Norway, it's the same as AUSSM here. I do work for the BJSM, and then recently for JBJS. So I have my fingers in here and there in orthopedics. But for the most part, I'm a practical sports medicine guy, actually. So I'm coming from Norway. Small country, actually not that small, but very few people. So the entire coastline is a very long one. We're on the Atlantic Ocean, and because of the Gulf Stream, it's not as cold as in Minnesota, actually. My sons were saying to me, why did we move to Minnesota? Much colder than Norway. So it's actually pretty nice. The picture you see here is the Olympic Training Center and the research center that we have very close to where I live in Oslo. And this is the office, the old hospital, that's the Olympic Center, and that's the Roald Bar. Roald is the sports science professor there, and co-chairing the center with me. Now, when I started out in research, or actually I should say this, when I started out as an orthopedic resident, I really didn't have any idea on what kind of research I was going to do. But then I had a clinic one day, and I saw they were doing these Maquet procedures for anterior knee pain. Anterior knee pain, the ones that you usually see on a daily basis probably. They did a lot of those Maquet procedures, which is elevating the tibial tubercle to relieve the stress on the cartilage of the patella. And I looked at that and I didn't think it was very smart. So I asked the professor, how are they doing? And he said, of course, like most orthopedic surgeons, he said, they all did well. So then I actually started to look at those, and I looked at about 40 patients and followed them for a little while, and I noticed that only about 10 of those 40 improved, and actually 6 were worse. The majority were the same as before. So that was the thing that made me become a researcher, a clinical researcher, and I realized that not all the screws I put in are put in perfect. And after this experience, I stopped believing in evidence-based medicine, only in evidence-based medicine. And there is a slight difference there. So I've become very evidence-based, I should say. And I'm a little bit of a skeptic, which is probably good as an orthopedic surgeon. I am a clinical researcher, though. And the quintessential clinical researcher in the world was Ponseti. You see him there? He's the one with the club feet, And he was 90 years old running a clinic when I was visiting him a few years back. He's now dead. But he was a clinical researcher the entire life. So he is an ideal person, actually. So I've done 25 years of ACL research, a lot of PhD theses, things like that. And I went to the US in 1987. Then I met a professor in biomechanics, Jack Lewis, who kind of taught me the real science. And that's how I became interested in biomechanics and in that type of knee problems. I brought a lot of Norwegians to come to the lab, and we developed several new procedures over those almost 10 years. This is Liza Arndt. She is a professor at the University of Minnesota, patellofemoral. She was the one that taught me that. I just want to show you that. But this is Rob Laprade, working in the lab in Oslo. And with him, I have developed posterolateral and posteromedial procedures. I'll just show you this now. This is the posterolateral procedure for patients with ACL plus various thrust knees. Many sports people have that. And we published extensively on this. I'll tell you. And then we went to the medial side, did the same thing there. This is our research team, Norwegians and Minnesotans. And this is very recently, actually, we've done this. And we come up with a new way of reconstructing the lateral side and the medial side. And we have clinical data, biomechanical data, all that kind of stuff. It works, and it's been picked up around the world, so it's very good. I like that. And then at the same time, I've been working with cartilage, and I have 2 long-term studies on the autologous transplants. I started out doing that in '97, so that's been an interest also. But what does all this have to do with what we're talking about today? Let me explain that to you, because this is a very practical approach that I have to this. Now, this is Susanne. She was the captain of the Norwegian team handball team. I'll show you some videos of team handball afterwards. And she was going to win the gold medal for Norway in the Olympics, Summer Olympics in Sydney in 2000. In 1999, or 8 months prior to the Olympics, this happened to her. Let's see if we can get this up here. Oh, sorry. There you go. So now you can see team handball very soon, how it goes. You can see her coming in from the left. It's going to be very slow. You'll see it much better, and then a little bit bigger than you see here. So you see she does a right-left fake. It's a very classic way of doing team handball, a little bit like basketball in one sense. Here you can see it hurts. And you can see what kind of injury she gets when this happens. Now, this happened 8 months ahead of the Olympics, as I said. And we did ACL surgery on her. She came back. She played after 8 months, of course, but she wasn't as good. She never became as good as before. Norway only won the bronze medal in the Olympics because of this. And later on, this is not her knee, but she has developed osteoarthritis. And that was not just because her ACL was gone. She had a lateral meniscal tear, lateral femoral condyle, and medial femoral condyle cartilage injury, just like you see here. And, this just reinforced the thought I had that surgery is not going to prevent osteoarthritis. Even if the player trains, does everything you say, it's not going to happen. And this is the newspaper article about her. It says, you can read it yourself. The knee stopped Susan from playing, from her career. She had to do that, and that's not the main problem, actually. She was 30 or 32 or something, but she can't even lift up her kid from kindergarten. She can't bend that far down and so forth because of osteoarthritis. So it is really a big problem that we have to solve. Now, when this happened in Norway, this was 2000, there was uproar in the public. Newspapers had everywhere, Norway was not going to win. And Norwegians are keen on sport. Really. That's the most important part of our life, probably. And so this thing was brought up to the parliament. This is the parliament building in Oslo, same as your Senate. And this is a politician from Labour Party, former team handball player. So she brought it up in the parliament. She said, we have this epidemic of ACL injuries among ladies, or young girls, actually. We have to do something about it. We have to find someone who knows about this and give them some money so they can do research on it. And that's how we got the $1 million US dollars to do research in our lab because we were the only ones, me and Roald, who actually had worked on this in Norway for a long period of time. So that's the background for our institute that I will talk a little bit about later now. But it was a very practical background, a little bit coincidental. We had applied for grants for a long time without getting anything. You know, this is not cancer, it's not cardiac problems and so forth. It's hard to get good grants in this area. This is the research center up here. And this is, I live down here. This is where I ski and bike, and it's a wonderful area to live in. Norway is a really nice country to live in. Very peaceful, usually very peaceful, I should say. So the STRC, Oslo Sports Trauma Research Center, was established in 2000, and you can read yourself after that. I'm just going to spend some time on this now because I want you, having a new center here, know what you have to do to be successful. This is Roald, this is our building. And what we started to do in 2000 was to establish a research program on methods of injury prevention, pathophysiology, risk factors, consequences. Then we were focusing on high-level sport in Norway, meaning soccer, team handball, alpine ski, freestyle, so forth. And then also long-term surveillance systems. So every ACL that's been put in Norway 2,000 a year is put into this registry. So we have now 16,000 ACLs in that registry that we can follow the patients forever in that sense. That's why you know so much about osteoarthritis and stuff in this patient group. And we started with acute injuries. Now we are into overuse injuries and some illness issues. So I'll show you that. You can find us on this website. And what we're doing there. And this is basically it, in saying it again. Now, we're not only dealing with Olympic athletes, of course. Norway has very few Olympic athletes, actually. We have a lot of gold medals from Winter Olympics, but not from Summer Olympics. So, actually, most of our research has been done in youngsters. And I would say 14 to 18-year-olds, that's been our lab persons, basically. And most of our, and in our center, we actually don't see patients. In that center, we only do the research on our patients. We see patients in a clinic and in the Olympic Center. And we're not only orthopedic surgeons, of course. We are all these kinds. We don't have any trainers, although there are no trainers hardly in any European country. They're all PTs with special emphasis on high-level sports. But the work of trainers are done by the physical therapists. So we have about 20 PhDs, 20 master students, and a whole bunch of people. So a big group. And one thing that's very important, and I will re-emphasize that for you as well here, very important to have international people coming in. Because this is truly an international field. And Norway being a little country, small country, we have to rely on people from outside as well. So every year we have 4 or 5 foreign-speaking countries, foreign people. Now look at this. This is from PubMed in 2000. If you ask for prevention in papers, you can have, or athletic injury prevention, you can have about 2,000 papers. It looks pretty good, right? But the thing is, they never did any prevention. The last sentence of that paper, or the papers, would be, and prevention should be done. That's a classic thing. But very, very little was done. Actually, only 6 papers were truly on how to implement or how preventive measures were working. So the field of science was very limited. Now, when we got the IOC grant, which was a competition between 30 centers around the world, 4 centers were picked. One was in Calgary, one was in Cape Town, and one was in Melbourne and in Oslo. They were picked based on education, clinical work, research, and working with high-level Olympic athletes. And I'll just show you what the others are working on. They all work on prevention of injuries and illnesses and how to protect the high-level athletes and normal population. Here's from Calgary, Vina Moivise here. Their work, and I'm just showing this to tell you that in various parts of the world, so much is going on various aspects. And you can never do all of it yourself. You have to spread it around and share your information that you have there. This is the relatively new study in JAMA. You may have seen it in hockey players in Canada, where they showed that checking among young hockey players is probably not the best thing to do. Yeah, you've seen this. I know hockey is very, very important here in Boston, of course, and I know you're doing it yourself. But this study has really high impact all over the world, not only in Canada. And it led to, or was part of the SCAT work, which is being done all over the world. And the SCAT forms are, if they're not being used here in Boston, they should be used. It's a very good way of looking at concussions in all kinds of sports. And the new one that just came out this year is the child SCAT. So if you don't know about this, look it up on the websites. It's a very good tool on the practical side, I should say. And ask me about that afterwards if you can't remember it. The second center is in Cape Town in South Africa. They are working on, for the most part, on overuse injuries. And also they are just doing a lot of work on Paralympic sport. There was a question about Paralympics here. Can we do this test on Paralympic athletes? And yes, we can, and we are doing it. Paralympics are being integrated into Olympic sports now. So you have to integrate Paralympic athletes in it. So that's what they do. Look at this. This is the from London this last year. The injuries were about 12% in athletes, and the injuries were about 13% in all the athletes participated in the Olympic Games in London. The regular Olympic Games had about the same. I'll show you that afterwards here. Problem is, Paralympics is not really being looked at very much around the world, and this is something that they do very well in South Africa. Now in Australia, in Melbourne, they do something else, which is very important. They're looking at how you can implement all the knowledge you have. So you showed us how to do this here very well, actually. And you were saying that, Sophia could do this. She could jump, and you could look at her, and you could say that she's at risk or not at risk, and so forth, and you can tell her this is what you have to do. The problem is that even if you tell them what they have to do, they're not doing it. And I'll show you a study on that one. But this is the best place in the world looking at the implementation, and that's in Melbourne. And so those three are part of our sort of group working in the IOC. Ourselves, this is from the Oslo group. And we are also working on very many different aspects of it. And when your center grows, you'll have to go into various aspects of it or form companionships with other groups in the US and around the world. So this is what we have been doing on injury prevention. I'll just show you this. This is, you're probably familiar with this. This is what you do in theory. And in practice, this is what you do. You look at the magnitude, you look at the causes, you look at how can you prevent them, and then you study it and test it. Very simple and easy. I'll show you one that's a little bit more complicated as we go along. So we have concentrated on team handball, and you have no clue about team handball here. It's the best sport for ACL science. Reverse than basketball, very bad. Skiing is also pretty good from a researcher point of view, because they also have a lot of injuries. I'll show you some of these. So if you look at the magnitude, let's just look at London first. What happened in London? It's not very long ago. We know a lot about what happened from injury and illness perspective. I don't share that with you. We published it all in BJSM. And the injury rate, 12% were injured during the games, meaning they had to be seen by a team doc. And if you look at Beijing, Vancouver, London, there is a slight increase in number of injuries in each Olympic game. And the illnesses is about the same. And it's a little bit concerned because the different sports have very different incidents of injuries. Why is that? Well, Taekwondo, for example. Taekwondo, you know what that is? Yeah, you do. That's a sport where they change the rules. All of a sudden, instead of getting 1 point for a kick to the head, you get 4 points. And that can change the game at all. And then, if you kick very hard, you get more points than if you kick very not so hard. So they changed it anyway. And the injury rate went up like this. And it's very interesting because when we looked at this from the IOC side, we saw all these injuries. We asked the Taekwondo persons, why is this happening? And they said, no, we have never seen anything like this. We haven't seen these injuries going up and so forth. So usually the international federation will be very protective of their sport, whereas we as sort of neutral researchers, we know that something is going on. So this is why we're looking at this, and we publish it around the world. Then let me go to some of the work we've done with the International Skiing Federation, and then go a little bit more into details on what we're doing. So FIS is the International Skiing Federation, has an injury surveillance system run by us to manage the risk and to do more in-depth research. And this is Tonje. She is an MD and now a PhD. So she's the one that does all this work. If you look at this is the alpine, freestyle, snowboard, and so forth. You can see that the time loss or all injuries are pretty big in those three: alpine, freestyle, snowboard. The other ski jumping and so forth are not really important here. You can also see that time loss in about 30% of the injuries. And if you are a high-level FIS skier, World Cup skier, 10% of those skiers will be done with the season, sometime in that season. So the injury rate is very high, no doubt about that. And the knee is the culprit, as you can see here, by far. No difference, but really difference between males and females, as opposed to soccer, basketball, team handball. Here it's about the same, actually a little bit more usually in males. So the big problem in the downhill skiing is, of course, ACL injuries. As you can see here, it's too much. 5% of skiers each season is too much. And then again, the faster you go, the more of a chance you have to be injured in that area. And as you can see here, not a very big difference between males and females. So I don't think that's so important, actually. Let's look at some of those causes here. You can see this one. You've seen this already. And you can see that it's a right-left fake. And she has an ACL, lateral meniscal tear, and lateral femoral condyle tear. And then you can see this one is probably even better. Coming here. And this is a classic injury in a classic sport in Norway. And in Europe, I should say. And so... And then you can, so it's hard to study this injury, actually. We have studied it extensively, of course, and we know what's happening. Valgus, loading, external rotation. But it's really difficult. And Trond Krosøv is a biomechanist in our work, in our center, and he's the one that has done most of this work. And this is a classic injury. Look at her, I think it's the right knee coming in here. It's going to have that. And when you look at this injury, it's very difficult for a researcher to say what actually happened. So what Trond did was to develop a computer model where you could actually place a skeleton into the person. And then you can look at the loads to the joints, the motions, the angles, and so forth, and then you can actually tell everyone what's going on here. You can do this in any sport. It takes a long time. And you get curves like this out here now. You can look at the hip flexion, knee flexion, and so forth in real time. So it is very useful if you really want to know what's going on in your sport to try to figure out how you can prevent it. And this is Hide Koga from Tokyo. He's been working with us for a couple of years. He's done this in several other sports also. And what he says is that what happens when you have an ACL injury in basketball, for example, you have a sudden valgus increase, you have a sudden internal rotation, and you get a compression in the lateral femoral condyle, or lateral tibial plateau, I should say. And then you have valgus, internal rotation, the compression, you get the ACL injury, you have the lateral meniscal tear, and you have the cartilage damage in that area. This is something that you see almost in all sports. And this is the theory that happens: valgus loading, total compression overloading. After ACL is torn, you get external rotation of the tibia. So this is very typical, actually, for what's happening. This is what we have to be able to prevent, and it's not easy to do that. So let me show you a couple of videos, and you can see yourself, on which leg is the ACL torn, and when is it torn, what happens here. I have a couple of slow ones. I can help you. It's the left knee, classic injury. I think this is the expert group, by the way, that looks at this. And they're from around the world, and they were there in Norway to look at what really happens. And they had some videos from the World Cup, and you can see here, this is going to be a fast one first. It's the, which knee is it? Right knee, right? You can see it right there. So what happens actually? We can look at it slow. No, let's see. We'll do next one. And this is a little bit more difficult because it's faster. It's downhill skiing, and it looks very bad. But actually, what happens is long before he falls, there is ACL, and then he has this injury. So this happens frequently in the downhill skiing, in the World Cup skiing. But look at his right knee. He loses the right ski, he kicks back, and his ACL is torn. It's called, I'll talk about that a little bit. This is the characteristics of it. And this is called slip catch. It's kind of a new expression. In the majority of the injuries in alpine skiing, you'll find that. As you can see here. There is one main mechanism for alpine skiing injuries like this. And if you go back and look at the poster then, you can follow that patient, or that skier actually, and see what happens to him. You have to have a camera from 2 angles, but if you have that, then you can actually measure all the joints, motions, and so forth, just like you're doing here. You get this, valgus, internal rotation, compression, same thing happens. And you can see this, how long that takes down here. So there's a pretty good match between what you can see if you're an expert and what you can analyze if you do a poster analysis. It's not easy to do, it takes a long time, and but basically the studies support what we've seen on videos before. So that's good, at least we know that. How about, then you know a little bit about the mechanism of what's happening. Okay, what about prevention? Let's test that, let's look at that. Well, we've seen this before, prevention works. But the question is, how well does it work? And Grete is our PT, PhD. She's the one that has developed these programs that you talked about in the US here, but she has done this in Norway. Very simple things. These are team handball players, but it could be soccer players and so forth. You see, they're not doing anything specific. They have to do it though 10 minutes or 15 minutes, 3 times a week. See, it looks very easy. And then she showed in the upper division in Norway, ACLs, before we did some of this prevention, during and then after. And if you didn't, and it doesn't look significant, it isn't, because there are too few players here. But if you don't do it, you have a 16 times higher risk of an ACL injury. 16 times, that's a lot. No doubt about that. But let's look closer to this one. Because she did one in the regular athletes. This guy did it in young boys and girls. He looked at about 1,000 with an intervention and 1,000 as a control and followed them for 1 year. And what he found was that if you just did simple things, warm-up, technique, taught them how to land, not do a right-left fake, not land with straight knees and so forth, balance, very easy work. And what he found was that he could reduce the number of ACL injuries and reduce the number of acute injuries to the ankle and the knee just by doing this. And there was a 50% reduction overall in injuries in the lower extremity by doing this. So this looks very good, and no doubt that it works. The problem is that it's hard to get them to do it. This is the FIFA 11. I noticed that you said 11. Actually, the new FIFA is 11 plus, which is a little bit more comprehensive than the 11 one. And this is a study that we've done in Norway prior to FIFA going out with this. And it shows this is in young people, 14 to 16 years old, not senior, not professionals. So we know that it works in kids. This is Torbjørn Soligard who did this, and I'll show you basically what they did here. Again, you can see it's pretty simple. Initial running, strength, exercise, plyometrics, balance, coordination, each with 3 levels of difficulty. That's important to have a progression in the level of difficulties. And then final running exercise. It takes about 20 minutes, 3 times a week. It looks very simple. As you can see, there's nothing hocus pocus about it. But then you can actually reduce all injuries by 30%. You can reduce overuse injuries and severe injuries. It does work in a research program. It does work. But let me show you a couple of other things. What can you as a trainer, PT or orthopedic surgeon do? Well, you can show them this, the same as we saw before here. You can do that. You have to tailor it to the specific sport because sports are different in respect to this. And the question then is, if you know the program, you know how you're going to design it, you know how to teach that to the coach, can you identify at-risk players? I know that you showed us that we can do that, and we are a little bit more skeptical to this. It looks very simple. This is a patient with good control, and this is a patient without a good control. Right? It looks easy, it looks simple. And then, if you look at this, make it a little bit more comprehensive. Good control, and then bad control. It looks obvious that the hip extensors are not very good in that lady. The problem is that when you do research on this, it doesn't show that if you do this and you identify them, you reduce the risk of the ACL injuries. Because even if you are like that, there are other people who are totally normal who also get an ACL injury. So in our hands, in patients in team handball who does right-left fake and they have this imbalance when you test them, they are actually improved if you tell them about this and they train very hard. But the ones who actually get their ACL from jumping, landing with an extended knee, you're not able to pick those out. They are about 50% of the ACL injuries. So this test probably, I'm a little bit skeptical. I know that you guys are more positive to this. I feel that that's difficult. But there's no doubt that these injuries are preventable. Absolutely. You can implement them nationwide or statewide here in Massachusetts. Yes, no doubt about that. And you can have results as we have. 3 different studies, team handball, women's soccer, or kids soccer I should say, and then boys soccer. Really good 50% reduction. That looks very good. I want to show you something that, and spend a little bit of time on this. And that's about implementation. Because you have all this knowledge. Even though you're lacking a little bit of it, you still have a lot. And then that's what we had too when we started out in 1999. And we told them about this, and sure enough, the injury rate went down. Then we didn't do anything more. We had physios working with the team. I was traveling around Norway showing it to them, but then I quit doing that, and sure enough, the injuries went back up, as you can see here. Then we started counting again after a few years, and actually we sent DVDs and stuff like that. Now we have this, of course, on the web to all the teams around Norway. Sure enough, then it went back down, as you can see here. Very good. And then, since then, we've gone on the web and we've been able to keep it down. So we seem to be able to do it, but it told us that when you go from being a very active researcher down here, and then you think that you've solved the problem, you really haven't, because if you leave the players or leave the coaches and trainers, it's going to go back up again. So even though we have all this knowledge that you have now, you're going to have injuries way up there if you don't figure out the way to implement them. It's a very difficult problem. This has been shown in smoking and in alcohol and other areas as well. But certainly, I don't think we have solved the problem. We have reduced the injuries of ACLs in Norway to 50%, which is good. It's bad for research because it takes longer to do a clinical study, but it's good for the patients. So that's very good. But I'm a little bit not so as optimistic for in other areas. Look at this again. In 98, 99, we saw that we went down and then went back up again. And now we are here and we show that it really works. So I think that this tells you that there is one important aspect where very little research has been done that's been in implementation. I'll show you one slide about that. But the good thing is, look at this slide now. There are 4,000 papers out there, or more now, probably this was 2010. 4,000 papers on prevention of injuries. And there are 150 studies, randomized control studies on various aspects of doing it. So that's very good. So we have the knowledge now, almost at least to do many things. But look at this again now. Here, if you're going to remember one thing from my talk, and that's the number 5 and number 6 here, to evaluate how you're actually having an effect on your high school team or your college team or whatever. That's the key here. That is very, very important. There are a lot of good stuff you can find on the web. Those of you who are working with soccer players, you should do 11 plus, in my opinion. Maybe the PEP program is probably almost the same, but this program is a very good one. This is very good for youngsters between 12 and 18. And if you go to the web, there are many languages, Spanish also, and there are videos, and you can download it all, and it's pretty good, I should say. You can go to our website. Then you have to read Norwegian. Yeah, I know. We are going to translate it to English. It will come out around Sochi Olympic. And the good thing about this, if you have a patient with, let's say, and a snowboarder with a snowboard ankle fracture, patient can go to the ankle over here, click on that, and you can look at it. Why does it happen? What kind of injury is it? How long will they be out, and so forth. This is a good tool, I think. So you can do that too. In addition, we have made so many tools that you can download from this and from the IOC website. So all you have to do is to learn Norwegian. Much of this is published in BJSM. I know that many of the Americans don't really read BJSM, probably because it's British. I don't know, maybe here in Boston it's because it's British. But it's actually a very good journal for you guys and for me, because it has everything on prevention is in there. There are 16 issues a year. 4 of them are issued by the IOC. And then we have the prevention studies in that one. Pretty good impact factor. One of the better sports medicine journals. So I'm going to show you what we had recently. Just look at these. This is from the last 2 years. And no doubt that we are very quick of getting research out, not only in regular Olympics, but also in Paralympics. And I think that you should try to at least go to the web and look at this journal. It's a very, very good one. And we are happy to have your studies come in there. Just send them to me. I will help you do this. The other thing I'd like to say is that we are starting something on Tuesday, actually. IOC is starting the IOC Diploma on Sports Medicine for MDs and actually physios. And this is something we're doing because in the Olympic Games, there are about 900 doctors. 12,000 athletes, 900 doctors. And the level of their skills are very different. And instead of traveling around the world and having courses, so we have made a web-based program that you can do for 2 years, and you then will get an IOC diploma, which is a master level diploma, actually. And it's not a bad thing to have if you're working with IFs, international federations, or NOCs, National Olympic Committees. If now, in about 5 years' time, to be able to go to the Olympics as a team doctor, or if it's or a PT, you have to have this course. So that's something that we're really trying to implement. The other thing I wanted to, at the end there, talk to you about is that we have something called the IOC Prevention Conference every 4th year. It's coming up now in Monaco, of all places, in April 2014. And this is something you can look at the website, and you may be interested in going there. You'll hear all the research going on around the world on the prevention of injuries and diseases. And towards the very end here, I'd like to show you this one, because this is a typical ankle fracture. And of course it's illegal play, so it's not very good, and it's probably very hard to prevent. But in my opinion, acute sports injuries, there is significant concern for the injured athlete, for sports organizations, for society. But I know now, after 10 years or more working in this field, that we actually can prevent them. All we need are people like you who actually can do it. All you have to do is to teach yourself some of the techniques, go to meetings like this, talk to the coaches and parents and so forth. This is an area where you can have a major impact. So, like myself, going from dealing with high-level Olympic athletes, doing their ACLs, getting them back to sport, and then they have osteoarthritis down the road. I did not like that. I don't like that. I still do it. But I feel much better about myself when I am in this prevention work. So remember, if you can remember, that second thing from what I said is that this is the most important task that you can put on as a trainer, physio, MD, and so forth. So finally, let me show you a couple of pictures here and relate that to what we're talking about. This is a mountaintop in western part of Norway, and you can see me climbing up there. In very good weather, so that's a little bit unusual. So I'm getting higher and higher up. It's very warm, so it was a tough climb. And I was very happy when I finally reached the top. This is a Norwegian fjord going out into the ocean is on the further out there. And you can see the steep mountains. It's very nice. So when you get up there, you are very happy, of course. But then, so you are sitting up there, and you are very happy. But then you feel, or I felt like a researcher. I looked around there, and I saw there were so many other mountains I hadn't been on top of, that I had to climb. And that's just the same as it is in research. We have a lot of knowledge, but there are so many things we don't know. So there's still a lot of work for all of you out there. Thank you.